Hello, I'm Conrad Fisher, and I'm the co-chair of medicine for Kaplan Medical. I'm the director of the internal medicine residency training program at Maimonides Hospital in Brooklyn, New York. I welcome you to engage with me in the process of studying for the preparation for USMLE Step 2. Through the process of studying these tapes and the notes, if you will invest the slightest bit of trust, the slightest bit of connection with the goal of passing your examination, augmenting your grade, and God forbid, learning some medicine that will spread a token of goodness and healing amongst the peoples of the earth, I will protect you and take care of you as you study for this examination. We're going to look at the structure of a question. We're going to look at how people learn. And the first part is questions are written largely in the format of you get a little history and a little physical examination. Maybe you get some laboratory tests, maybe you don't get some laboratory tests. And then you can be asked certain basic questions from this point of view. The most important thing in your preparation is to think in the form of someone who is writing a question. Ray Bradbury in Fahrenheit 451 says, if you want to learn how to find, you must first learn how to hide. If you want to learn how to answer a question, you must first learn how to think like you are writing the question. From this point of view, you can be asked a couple of basic questions. One is, which of the following is the most likely diagnosis? Now, this is particularly more on internal medicine because internal medicine docs like to sit around and think about the diagnosis. They get some history, some physical, some labs. They go, is it a this, is it a that, and is it a this, and is it a that? And they take hours to make any sort of decision or take an action. And they agonize over the diagnosis until they perforate their duodenum and get an ulcer. So that's about 20 or 30% of the questions, more on internal medicine, a little less on surgery, because people don't go into surgery. People don't go into orthopedics to go and say, what's the diagnosis? Bone broken. Shotgun in head, hole in head, fix all. Now, in addition, you can be asked from the same history and physical and labs, which of the following is the best initial diagnostic test? What would you do first to diagnose the patient or confirm your diagnosis? What is the best initial diagnostic test? At the same time, you can be asked, what is the best, the most accurate diagnostic test? All off of the same history and physical and labs. You will study thinking of these questions because you're going to get asked. So you might as well study thinking about them. So that way, when you need to pull the information out of your brain, you'll be able to pull it out with the same ease that you fork or spoon a spoon of food into your mouth. Right now, your mind is like a cutlery drawer in your kitchen. The forks, knives, spoons, and everything else thrown in a jumble into a big pile. You want a fork, and you've got to wedge it out and yank it out, and you can't find it because it's buried underneath everything else. This way is simply saying, forks, spoons, knives, which of the following is the best initial therapy? The same way, organizing all the information in your brain to answer question by question. When you learn how to think in this way, you will learn how to answer questions in this way. All right, and at each point can simply be asked, what is the next best step in the management of this patient? Now, I know this may seem all very straightforward. That seems obvious. That seems straightforward. Didn't I know that? I knew that, right? I knew that. That's easy. I knew that. But the problem is that the questions sometimes say, what is the best initial diagnostic test? And you think they mean, what is the most accurate diagnostic test? Sometimes the questions say, what is the best initial therapy? But you think they mean, what is the most effective therapy? And you say, oh, no, I don't do that. I don't do that. No, I don't do that. Oh, but yes, you do. Yes, you do. You do because everybody does. The question says, what is the best initial diagnostic test? And you answer, what is the most accurate diagnostic test? The question says, what's the most accurate? And you answer, what is the best initial? Because you're answering based on what you think the question writer means, rather than answering what the question writer is saying. Now, the difference between law and medicine is that in medicine, what you mean is more important than what you say. Whereas in law, what you say is more important than what you mean. Maybe think about it, you say it like this. Hey, you're supposed to give me $200,000. Oh, but that's not what the contract says. Oh, no, you're supposed to give me $200,000. But the contract says I'm supposed to give you $1.50 and a soda. No, but you meant... Oh, it doesn't matter what I meant. What did it say? Ah. And that's like the process of preparing for a licensure examination. You have to answer what exactly it says, rather than what you think they mean. Now, I know a lot of you will say, I don't do that, I don't do that. That's not my problem. Really? Then why are you here? Oh, I had nothing to do with a few weeks of my life. A few $1,000s. I'm doing this for entertainment purposes. Think this through. Trust me, trust me. The other thing is, in terms of our interaction with each other over the next couple of days of our short but extremely intense relationship, I just want you to know, I'm not like all the other boys. I'm not like them. Now, what I'm going to do and say is going to seem different from other people that you've been with before. And that's good, because that way it will create memory, okay? It will seem instinctive in your mind. Don't get upset. Don't get offended. Don't get distracted. Trust me. Trust me. I have danced this dance before. And here in the middle of the year 2001, now makes the beginning of my 10th year of doing this, and some 30 or 40,000 students. Trust me. It will work, okay? It has to create a certain amount of memory. So let us start with the ideas of cardiology. You have a 47-year-old ovary-possessing person who comes to your office complaining of chest pain. Now, let me make a suggestion to you. Don't just read notes in class with me. Don't just read notes in class with me. Reading notes in class while watching me at this time is kind of like going to the movies and reading the book that the movie is from while you're in the movie. What's the point in doing that? Try to recall, because at some point in the past, 80% of this material has crossed your brain before. It just didn't retain. You had an intellectual malabsorption. There's a little pile of information underneath you at the end of the day. It didn't retain. So it's gone through you before, it just didn't stick. Whereas doing it this way, of trying to recall, trying to think, is more like intellectual tattooing. It will stick more, and it will stick more. So don't just read notes in class. Take notes on what you don't know. Then you'll go with the book notes, the class notes, the book notes, the class notes. Pull out for a wider image. Pull the book notes and the class notes. And then you'll combine them later on. Sort of like pulling up a zipper in a way. And you say, but that will hurt more. That will take more time. That takes more effort to take the class notes and the book notes and combine them later on. That feels like it takes more effort. It feels like it takes more effort. Do you know why it feels like it takes more effort? Do you know why? Because it is more effort. That's why it feels that way. And who cares if it's more effort now? All that matters is your Step 2 grade at the end, right? That's what matters. Think with me and interact. Then you'll go with the book notes later on. Okay? She comes to your office with some chest pain. The chest pain has been going on for months. It is intermittent, and it is exertional. Sometimes it happens when she goes up 2 flights of stairs. Sometimes it happens at rest. Sometimes it happens every time she walks up a flight of stairs. Sometimes it happens at rest. Sometimes she walks up 3 flights of stairs and nothing happens. It's intermittent. It's atypical. It's strange. She's got ovaries and she knows how to use them once a month during her menstruation. She's got some nausea and she's got some vomiting, and the chest pain is substernal in location. We have substernal chest pain, female, youngish, nausea, vomiting, bad taste in her mouth. Which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial therapy? What is the most effective therapy? She has past medical history of avidya. On physical examination, she is found to have avidya. On past medical history, she is found to have lots of nothing. On past medical history, which of the following is the most likely diagnosis? In a 47-year-old woman who has chest pain that comes and goes, sometimes exertional, sometimes it's not exertional. What's the diagnosis? Oh, this is your part. Yes, I know. I'm very bitchy and demanding. I understand that. What? Who, me? Oh, you must. Thinky. I know. Like, no, the other thing is, try and think of this like group therapy. Because, basically, it doesn't matter if you're wrong, does it? It doesn't matter if you're wrong. Try and think of this, okay? Now, you two out there in videotape land, you think too. Don't be looking down at those notes. I see you looking at those notes. Don't do that. Engage. The information I'm giving you here is 90% the same information that's in the notes in front of you. It's in the books. It's in First Aid for the Boards. It's in the current diagnosis book. It's in every textbook. It's in Cecil's. It's in Harrison's. It's in those underground clinical vignettes. Like a restaurant, an expensive restaurant, 14-point print, 3-inch margins, lots of pictures. Keep turning those pages really fast. Like those expensive restaurants with the 3-inch steak and a 2-foot plate. The information is all around you. Where is it? It doesn't retain. You're not just here for information. I know that you think that you're here for information. I could just tell you the answer, but it won't stick. I could just tell you. You think that you're here just for information, but the information is all around you. You could have gotten photocopied notes from your friends and saved yourself a little do-re-mi. But that's the difference in the experience, isn't it? So what's the most likely diagnosis? We're chanting. We've gone up from silence to chanting. That's a good sign. Trust me. I'll never hurt you. GERD. Reflux disease. Reflux disease is the most likely thing. Reflux disease is the most likely thing in a woman. Woman possesses ovaries, no significant past medical history, intermittent fuzzy pain. Reflux disease. Now here's the other thing, statistically speaking, when you have chest pain and it's not cardiac, when you have chest pain and it is not cardiac, what is the most likely cause? What's the most likely, most common cause of non-cardiac chest pain? Better. I could be saying pizza with pepperoni for all I know. I don't know. Could be, it's GI things. GI things is the most likely thing in terms of people who have cardiac, chest pain that's not cardiac, is reflux and all the other gastrointestinal things. Gastritis, esophagitis, duodenitis, peptic ulcer disease, gastric ulcer disease, reflux disease, all the GI things. That's the most likely diagnosis. What is the best initial diagnostic test? What's the best initial diagnostic? Where's the right here? No, for this person. What's the most likely thing? EKG. EKG is the most likely. Now, why didn't you say a 24-hour pH monitoring? Why not an upper endoscopy? She got us right. She's right. She said EKG. EKG. But she didn't say pH monitoring. She didn't say upper endoscopy. She didn't say, put a manometer down my throat, why don't you? No, I can't. I'm not ready. No, she didn't say any of that. She said the thing about an EKG. But the most likely thing is reflux. EKG doesn't show anything in reflux. Why would I do an EKG when that's not the most likely diagnosis? There has to be an answer. Why? Rule out the most dangerous thing first. Rule out the heart first. So therefore, the best initial test is to rule out the most dangerous thing first, even though it's not going to lead to the diagnosis. Now, if the question said, which of the following is the most accurate, then it might be pH monitoring. Then it might be upper endoscopy, because that's the most likely diagnosis. Initial, rule out the most dangerous thing. I have chest pain, even if I don't think it's cardiac, get the EKG anyway. Has anyone ever been hurt by a normal EKG? I don't think so. Did anybody ever get in trouble for getting a normal EKG? I don't think so. I'm a juicy guy. So get the EKG first. So she has no past medical history, and her physical examination shows nothing, and she's got nothing else on history. And then she says, by the way, did I tell you that I've had diabetes since I was 17 years old, and I've been taking insulin for 30 years? Did I tell you that I have hypertension? Did I tell you that I have types 1 to 47 hyperlipidemia and a low HDL? Did I tell you that I smoke 3 packs per day of Marlboro Regulars? By the way, did I tell you that my mother and my father and my dog all died at the age of 47? Of a myocardial infarction? Did I tell you that I'm hypertensive, hyperlipidemic, diabetic, tobacco smoking, obese, sedentary, type A, lazy, and everybody died in my family at the age of 47? What's the most likely diagnosis in this patient? What is the most likely diagnosis? Now you have a 47-year-old lady who comes in with a past medical history of diabetes, hypertension, hyperlipidemia, tobacco smoking, low HDL, and a positive family history, and she says, I've got chest pain. What's the most likely diagnosis? Ischemic heart disease. Ischemic heart disease. By the way, guys, wrong answers are not reported to residency directors, okay? So I know it's all intimidating and I'm all scary and all this. I mean, oh, woo, woo, woo. But it's okay. It's okay. Just go ahead. Okay? So she's got all of this and all this. What's the point of knowing risk factors? What's the point of knowing risk factors? The point of knowing risk factors is that you can tell, one, which things to correct your subsequent risk of a myocardial infarction. How do you correct the subsequent risk of myocardial infarction? I fix the this and the this and the this and the this, and she has less risk. The other thing is in diagnosis. Now, if I gave you a 67-year-old man with chest pain, you'd go, cardiac, because we expect you to think all of us guys deserve to die of heart attacks eventually. I know you think that. Okay? So, but in a 47-year-old woman, those risk factors are useful to help establish a diagnosis. Now, when you correct these risk factors, correcting these risk factors, what a coincidence! A, B, C, D, E! What a coinky-dinky. Correcting which of these will improve the outcome. Correcting which of these will decrease her risk of subsequent MI. Correcting which of these will improve her long-term survival. Which of these is good to fix, guys? Which one, huh? All of them. See, why don't you do like him? See, he sits behind the pillar. No one else can see him, and he changes his voice. Normally he speaks like this. Hi, guys. And then he goes, all of them. All of them. I put on my testosterone patch just for this class. No one will know who I am. Correcting all of these. That is good. Yes, correcting all of them works? Or tobacco smoking? Huh? Tobacco? No, all of them. Tobacco smoking? Why did you say tobacco smoking? Speak, speak, speak. I think I read it someplace. The only factor that can improve life or survival is to quit smoking. I think you read it someplace. This is something like I used to do with penthouse letters, I think. I think I read that somewhere. Did that make it on tape? Oh. I read it someplace. Ah. But you don't, wait. Let's make him right. You don't have to have the right answer. Have any answer. I will bring you a question. I'm an intellectual waiter. Hi there, may I take that order? Okay. Now, let's see. The problem is you gave us the appetizer when we asked for the entree. Okay? All right. And I said, correcting which of these will improve outcome? And the answer is correcting all of them will improve outcome. If you stop smoking, lower your blood pressure, fix your lipids, correct your diabetes, raise your HDL, and raise your HDL, it will improve your subsequent risk. Now, correcting which of them results in the most immediate, earliest improvement in outcome? Tobacco smoking. So your answer of tobacco smoking has to do with, if you fix these things, which one makes me live longer by this time next year? Now that's kind of a stupid artificial board question, but then again we're studying for stupid artificial boards. You know, as if you like this, as if the patient was going to come to the office and be like this, you know what, I think you've got 5 risk factors. I'm only going to correct one of them. So I'll have you stop smoking because that'll result in the greatest single improvement. Yeah, you're on a very, very bad managed care plan, and I'm only allowed to correct one of your medical problems. So we'll have you stop smoking because your plan doesn't cover more than correcting one problem. And that results in the greatest immediate improvement in outcome, is stopping tobacco smoking. Now, what is the most common risk factor for coronary disease and myocardial infarctions? What's the most common risk factor? I know you want to talk to me. I know you do. But you're shy, just like me. What'd you say? Hypertension is the most common risk for myocardial infarction and ischemic heart disease. There are 16 million diabetics in the United States, but there are 60 million hypertensives in the United States. So there are 5 times more hypertensives. So fixing the hypertension is the most common risk factor. Tobacco smoking improves your outcome the fastest. Correcting all of them is a good thing, and risk factors are good in this case to determine what the most likely diagnosis is. Most common cause questions are simply epidemiology and biostatistics. Most common cause questions are epidemiology and biostatistics, meaning, what's the most common cause of myocardial infarction? Well, what's the most common disease? Hypertension. It's like this. What's the most common cause of bronchitis? What is the most common cause of, pardon me, I screwed that up. I was going to say, what's the most common cause of hemoptysis? Thinking forward. What's the most common cause of hemoptysis? TB causes hemoptysis, and cancer causes hemoptysis, and mitral stenosis causes hemoptysis, but none of them are as common as bronchitis. So bronchitis, although it doesn't cause hemoptysis very much, bronchitis is much more common as a disease. Another one would be, what's the most common cause of atrial fibrillation? What's the most common cause of atrial fibrillation in the United States? It's hypertension, because hypertension is the most common cause of disease. Mitral stenosis causes AFib, and hyperthyroidism causes AFib, and pheochromocytoma causes AFib, and pulmonary emboli cause AFib. Yes, they do. Yes, they do. Yes, they do. But they're not as common as hypertension. And that's why hypertension is the most common cause of AFib, because it's simply much more common than TB, than cancer, etc. Now, cancer, lung cancer, yes, it's the most common cause of cancer death, but you still have only 200,000 or 180,000 people a year dying of lung cancer. Pardon me, of having lung cancer each year. 450,000 a year die of tobacco-related disease, about 2/3 from COPD, 1/3 from cancer. But that's nothing compared to the millions and millions of hypertensives. Mitral stenosis causes AFib, pheochromocytoma causes AFib, but they're not as common as hypertension. Most common cause, statistically, what's the most common disease? So we have a 47-year-old ovary-possessing person who comes to your office with substernal chest pain. That's intermittent and exertional, and at rest, nausea and vomiting. And she says that the pain either change with respiration. In other words, is it pleuritic? And change with bodily position. And the chest wall is tender. Now, does myocardial infarction pain change with respiration? It never changes with respiration? MI pain goes like this, pleuritic. Meow, I. Get eye tack every time you take a deep breath in? Get chest pain? Does MI pain change with respiration? Well, the thing is, there's an advantage of having a board test. Yes, there's an advantage of taking a board test. Because in life, anything can be anything. In life, anything can be anything. In life, you can have a chest pain, you can have a myocardial infarction with no chest pain. In life, you could have a myocardial infarction with a normal EKG. But if they say, hi, I'm here in the emergency room. I have no chest pain. I have a normal EKG. What have I got? MI? No, that doesn't work. You see, there's an advantage of taking a board test. And the advantage of taking a board test is that if they want you to know the answer, they have to tell you something. If they want you to know it's a myocardial infarction, if they want you to be able to answer the question, which of the following is the most likely diagnosis? They have to tell you something. Other than that, no one could know the answer. 4% of the time in life, 4% of the time, MI pain is pleuritic. 4% of the time, myocardial infarction, a guy will come in and says, "Aye, that hurts. Oh, it's pleuritic. Aye, a change with respiration. Oh, that hurts, Daddy." But on the boards, if they tell you that it's pleuritic, they're saying it's not an MI. Now, which things are pleuritic? What forms of chest pain? What forms of chest pain do change with respiration? What forms of chest pain do change with respiration? Hi, that are pleuritic, that, get worse when I take a deep breath in. What forms of chest pain get worse with respiration? That's you. Come on. Double click on the brain icon, huh? Pneumothorax gets worse with respiration. That's correct. I know. Don't look into his eyes. Don't look into his eyes. Shield your eyes. I understand. What other forms of chest pain are worse with respiration? Pleurisy, viral pleurisy, that's right. Inflammation of the pleura from viruses. Pleurisy, that's right. What else is worse with respiration? Pneumonia, pericarditis get worse because pneumonia causes inflammation of the pleura. Inflammation of the pleura results in changes of pain when you take a breath because the inflamed pleura rubs against each other with pneumonia.
Pleuritis, because that's inflamed pleura. Pericarditis, because it's the other side of the pleura. Not the pleura that's out here, but the pleura that's in there. In between your heart and those lungs. Yes, and you have pericarditis, pleuritis, pneumonia, pleuritis. Pneumothorax, inflammation again on the pleura, and one other thing. Huh? Costochondritis, almost. I want costochondritis to be it. I'm dying for it to be it. And I want you to be happy. But I can't make it it. It's not really that much in terms of this problem. Pneumonia is pleuritic. Pneumothorax is pleuritic. Pericarditis is pleuritic. Pleuritis, pleurisy, pleurodynia, the devil's grip, Bornholm's disease, viral pleurodynia, whatever you want to call it. And what else is pleuritic? One other thing. Think, do like this. It's in your brain. You see, it's in your brain. Plato says that all of the knowledge and secrets and beauty of the universe are inside you already. You have only forgotten them. Did you know that? It says that all of the knowledge and secrets and grandeur of the universe are inside you, and you can't remember them. And so is the answer to this question. Huh? B! Yes, pulmonary embolus. I told you. Pulmonary embolus. Pulmonary embolus is pleuritic. Now, do you notice something about those? Do you notice? Yes, isn't that convenient? All the pleuritic things begin with P. Pericarditis, pulmonary embolus, pleuritis, pneumothorax, pneumonia. And they all begin with P. Yes, how convenient, what a coincidence, okay? Now, how are you going to tell pneumothorax apart from the others? Pneumothorax and PE. How will you help distinguish these two from the other things? How will you help distinguish those two? Huh? Physical exam, to a certain degree, yes. What do you mean? Auscultation. The problem is that the lungs can be clear in all of these. The lungs could be clear in all these, and the problem is that you can have Ralls in pulmonary embolus, you can have Ralls in pneumonia, you can have Ralls in a myocardial infarction, so that won't be good enough. Presence of Ralls won't distinguish enough, clear lungs won't distinguish enough. How do you think? Do this. Trust me. Flail chest. Ow, ooh, ow, ooh. Well, flail chest, the guy comes in and says, flail chest, well, yeah, but that's not any of the answers that are on the board, though. The major issue is that in pneumothorax and pulmonary embolus, the patient will complain of predominantly shortness of breath. In other words, pneumothorax and pulmonary embolus are people who come in and say, hi, I'm short of breath. I also have some pleuritic chest pain. Pulmonary embolus is people who come in and say, hi, I can't breathe. I'm short of breath. I get winded. I also have some chest pain. Myocardial infarction is, I have chest pain. I also have some shortness of breath. So ischemic pain is pain, hurt, chest pain. I also am short of breath. These are, I'm short of breath. I might also have some chest pain. That's the main thing. That's the main thing. And of course, these people are short of breath because they are hypoxic. Whereas in myocardial infarction, you are not particularly hypoxic unless you get congestive failure. Now, so that's how you're going to tell. You're going to say, pain does not change with respiration. Pain does not change with respiration. Does not change with respiration. Does myocardial infarction pain change with position? Does it change with position? No? MI pain? Well, you know, in life, 4% of the time, 1 out of every 25 people do have chest pain that changes with position when they have a myocardial infarction. So 4% of the time in life, myocardial infarction pain is positional. But not on the boards. When they tell you changes with position, they're telling you that it's not an MI. When they tell you it changes with position. Which form of chest pain changes with position? Pericardial effusion. Oh, I want the pericardial effusion to change the position. I'm dying for it to, but it's not true. You didn't mean to say effusion. You didn't mean to say that. I told you, think of this like group therapy. Think of this like group therapy. Okay, pull out the camera so you can see I'm actually talking to somebody. They're going to think I'm alone in my apartment. There's nobody here. Okay? Okay, who is he talking to? Okay, so the point is that it's not tamponade. What does he mean to say? He said pericardial tamponade, change with position. That's close. Pericarditis. And you're probably going like this. You're probably saying, oh, yes, that's right, right? Yeah, it's not tamponade. It's pericarditis. Pericarditis that is positional. Pericarditis that is positional. Now, is it pain that gets better when you lean forward, or is it worse when you lean back? It means the same thing. Better when you lean forward, you relieve the stretch on your pericardium. Worse when you lean back, you stretch that pericardium and it goes, ow, stretch, that hurts my pericardium, ow. And it gets better. Can you hear me now? Stretches the pericardium. So it's positional. It's the only one that's positional. And, of course, the chest wall should be non-tender, because the only one that's tender is... Costochondritis. Costochondritis is the only one that's tender. It's the only one that's tender. Now, which of these can give you... which of these can make you short of breath? All of them. So that's not going to help you, right? If a guy says, I'm having even a costochondritis or rib fracture can make you a little short of breath, even if it's just a catch. In other words, anything that gives you pleuritic pain can simulate shortness of breath. Anything that can give you pleuritic pain can simulate shortness of breath, because you go, ow. And you're splinting. You don't want to take a deep breath in, so you're splinting. Ow. So it can feel a little shortness of breath if you're not actually hypoxic. So any of them can make you a little short of breath. How will you tell pneumonia apart from the others? How will you tell pneumonia apart from the others? What does what? Huh? Symptoms. Everyone has symptoms, son. I have symptoms right now. How will you tell pneumonia apart from the others? Huh? Everybody has a physical. Fever. Oh, fever. Okay, yes, that's true. Pneumonia will have fever, and only pneumonia has fever, and pneumothorax. Only pneumonia and pneumothorax have a fever, and it's only pneumonia and pneumothorax and pulmonary embolus that give you a fever, because it's only pneumonia that gives you fever, pneumothorax, pulmonary embolus, and pericarditis and pleuritis that give you a fever. And because in the case of myocardial infarction, if you actually had an MI, that would, of course, only give you a fever, too. So fever, pneumonia, of course, it's an infection. So, of course, you get a fever. Pleuritis is an infection as well, so you get a fever. Pericarditis is either infection or inflammation. It's either infection or inflammation. We'll be covering that at 3:17 this afternoon. Okay? So... that's either infection or inflammation. Yes, that's true. Why does a pulmonary embolus give you a fever? Why does a pulmonary embolus give you a fever? Good. See, look, she does it. See? Look. See? Why does a pulmonary embolus give you a fever? Pulmonary embolus gives you a fever. Why? What? Infarct to the distal site, that's true, that's partially true. But the problem is that even without an infarct, you get a fever from pulmonary embolus. Even without an actual infarction, you can still get a fever from a pulmonary embolus. Even without, that's good, that's good. Now, you know what's good here? First of all, you're actually following suggestions. That's one great thing. You see, in New York, everybody's like this. Nobody trusts anybody. Actually, people trust each other a little bit more now. But you know, most of the time, they don't trust anybody. I say, don't read your notes, and they go, no. I'm going to read them because he's here to hurt me. I don't trust him. He wants to hurt me. He wants me to forget everything. So what's good about what you're doing now is I could see the norepinephrine crossing the synapse. You know what I mean? I see the thinking, even if you won't do that. I can still see you thinking. Pulmonary embolus gives you a fever because it is, what? It's a clot. Not because of pain. Pain does not give you a fever. Not physical pain, not emotionally pain. Okay? But it's a clot. And anytime you have a clot, you can have fever. Any clot and any collection of blood can give you fever. So you don't want to learn everything as isolated little factoids. That hurts. Isolated little facts, why, that's like taking an intellectual enema. Each little fact going in, you could receive it, but it's so painful, and you have to stretch for every little drop you get. Okay? So therefore, don't little fact, pulmonary embolus gives a fever, DVT gives a fever because it's a clot. Any clot will give you a fever. Any clot and any collection of blood. So that means don't learn it separately, because in pediatrics, when you have hemarthrosis in a child with hemophilia, that gives you a fever. When you are in the OB section and you have the ruptured ectopic pregnancy, blood in the cul-de-sac, if you had a ruptured ectopic pregnancy and you had blood in your cul-de-sac, okay? And if you had blood in your cul-de-sac and you had on choledocentesis all that blood, you'd have a fever just because of the rupture of the ectopic, right? That's right. So we'd have to take that blood out of your cul-de-sac, correct? Yes, that's correct. So any clot and any collection of blood, from a subdural to a subarachnoid, hemarthrosis in a child in the ped section, ruptured ectopic pregnancy, pulmonary embolus, DVT, all of them can give you a fever. Any clot, any collection of blood. Why does a pneumothorax give you a fever? Why does a pneumothorax give you a fever? Inflammation. You don't really get that much in the way of inflammation with a pneumothorax, not inflammation. Thinky, 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 or whatever version you have. Whatever you need to do. Pneumothorax! Yes, it gives you a fever because it's... You find that a little hard to swallow. Atelectasis pneumothorax. Oh, that's supposed to be where, on another gyrus, in another part of your brain, did you not know that atelectasis can cause a fever? Atelectasis can cause fever. For instance, surgery, right? You have the surgical section. Okay. So the thing is that you have it's surgery, post-operative fevers, atelectasis from pneumothorax, atelectasis from just any form of collapse, post-obstructive pneumonia can cause a fever just because you have atelectasis. So any form of atelectasis can cause a fever. Did you know that atelectasis can cause fever? But you didn't make the connection to pneumothorax. So in one part of your brain you have pneumothorax, and another part of your brain you know that atelectasis causes fever. But they're not passing. It's not passing your corpus cavernosum. Getting across. Okay? And why is it that a myocardial infarction gives you fever too? Why? You know, before there were CPKMBs, before there were troponins, before there was LDH, we followed a myocardial infarction with white count, sedimentation rate, and body temperature. And an MI gives you a fever too. Pourquoi? Why? Because it also is a clot. A clot. All of this in brains do. That's right. A clot. A clot. It is a clot as well. It is a clot in your myocardium. It is a clot in your coronary artery. So an MI can give you a fever too. Now, here's the story. You see this? Fever won't help you. Shortness of breath won't help you. Physical exam, except for chest wall tenderness, does not help you in terms of reliably determining the diagnosis. Okay? It won't help you sufficiently. Nausea, vomiting. How about being diaphoretic and sweaty? How does this distinguish these? Which of this is it? If somebody comes in and they're diaphoretic, they're sweaty, that tells you it's which one? Any of them. Any of them. Any of them. Okay? Here, step on my toe. Oh! Oh! Sweat, 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 sweat. Tachycardia. Pain. Sweaty. Pain. Tachycardic. Sympathetic outflow. Constriction of blood vessels. I'm pale. Pallor's not going to help you. Are you pale today? Is he pale? Is he pale today? I don't know. Are you pale today? Maybe it's on a pale day. I don't know. Who can tell who's pale? Are you pale? No. Maybe it's a good tan for you. I don't know. Okay? I don't know. Who can tell? Who can tell? Pale, cold, clammy. Maybe you sweat like that all the time. I don't know. All right? So the point is pallor, cold and clammy extremities, sweating and diaphoresis, tachycardia. All that could just be from anything that causes pain. Doesn't distinguish it. Sense of impending doom. My favorite, Levine's sign. Oi! Oi, this is my chest, oi! Oi! Ooh! That's not going to help you. Here's the point. What's the most common cause of death in the United States? Myocardial infarction. MI, heart attack. MI. Now that's certainly in men. However, in women, what's the most common cause of death? Huh? Yeah, it's the same. And even for women, if you take causes number 2, 3, 4, and 5 and add them together, it's not as much as myocardial infarction. Even for women. Even for women, number 2, 3, 4, 5 added together is not as common as an MI. For every 100 people who go to the hospital with chest pain in the United States, 50 of them have a problem that's not cardiac at all. Only half of them even have a problem with the heart at all, much less a myocardial infarction. Out of every 100 people who go to the hospital with chest pain, how many of them actually end up having an MI? It is less than 10% actually have a myocardial infarction. About 10% have unstable angina. 10% have unstable angina, about 10% have an MI. Do you know what this means? It means for every 100 people like this, for every 100 people like this, for every 100 people like this, that you have at least 90 of them that don't have an MI and 50 of them that have one of these things or the GI complaints. Have one of those things or the GI complaints. So therefore, you have to have the ability to distinguish between the different causes of chest pain. And it's largely based on positional, pleuritic, tender. Positional, pleuritic, and tender. Okay? And that's how you'll be able to distinguish these things. Positional, pleuritic, and tender, and not all the other things. Okay? That's like right here.